All right, hello to all you third-year BDS students. Welcome. Today, we're going to dive into something that's absolutely fundamental for your clinical work, dental local anesthesia. We're going to break down exactly what's inside that little cartridge, and more importantly, we're going to master the calculations that keep your patients safe. So, let's get right into it.
First up, let's just think about this for a second. How is it even possible to do some pretty complex dental work on someone who is wide awake, totally aware, and comfortable? How do we get that profound numbness in one specific spot without, putting the person to sleep? Well, the answer is all in the beautiful science of local anesthesia.
So what exactly is local anesthesia? The textbook definition is a loss of sensation in a circumscribed area without inducing a loss of consciousness. And that right there is the key. Unlike general anesthesia, we're not shutting down the whole system. We're just targeting very specific nerves, putting up a roadblock so those pain signals can't even get to the brain. It's targeted, it's precise, and honestly, it's what makes modern dentistry even possible.
Now, there are a few key players in this field, the usual suspects, if you will. Today, we're really going to focus on lidocaine. It's pretty much the gold standard because it works fast and it's super reliable. But you'll also see agents like bupivacaine, which is great for longer procedures, and articaine, which is known for getting through bone really well. Getting to know the pros and cons of each one is going to be a huge part of your clinical decision-making.
Okay, let's get to the real heart of it. What is actually in that little 1.8 milliliter glass cartridge? It's not just one thing. Oh no, it's a very carefully mixed cocktail where every single ingredient has a super important job. Think of it less like a simple solution and more like a high-performance toolkit, all packed into this tiny vial.
So, the star of the show, the main event, is the anesthetic agent itself, in our case, lidocaine. Its whole mission in life is to be a signal blocker. It gets inside the nerve cell and literally sits on the sodium channels, blocking them up. And if those channels are blocked, a pain signal can't even start. It can't be generated, it can't be sent. No signal, no pain. It's really that simple.
But the agent doesn't work alone. Next up is its powerful sidekick, the vasoconstrictor, usually adrenaline. By making the local blood vessels narrower, it does three incredibly important things for us. One, it keeps the anesthetic right where we injected it for longer, which means the numbness lasts longer. Two, it slows down how fast the drug gets into the bloodstream, which is a huge safety feature. And three, it helps control bleeding at the site, which, as you can imagine, is super helpful. It's a total triple win.
Now, adrenaline is amazing, but it's also a bit fragile. Oxygen can break it down pretty easily, and that's where the reducing agent sodium metabisulfite steps in. You can literally think of it as the vasoconstrictor's personal bodyguard. It sees any oxygen floating around and basically sacrifices itself, reacting with the oxygen so the adrenaline doesn't have to. This keeps the adrenaline stable and effective.
And finally, you've got the rest of the support team. There's a preservative to give the cartridge a decent shelf life, a fungicide to keep any nasty stuff from growing in there, and the vehicle. That's just distilled water and a bit of sodium chloride to make the solution isotonic. That just means it matches your body's own fluid, which makes the injection way more comfortable. Oh, and that little nitrogen bubble you see? That's there to keep oxygen out and protect that all-important vasoconstrictor. See? Every single part has a purpose.
Okay, so now we know what's in the cartridge. We get it. But now comes the part that really separates the student from the safe, confident clinician, the math. And look, don't freak out. This isn't about passing some terrifying exam. This is about you understanding the fundamental principles that protect your patient every single time.
Let's start with a constant, a number you just need to burn into your memory. One standard dental cartridge holds 1.8 milliliters of solution. 1.8 ml. That's our baseline. That's the foundation for every calculation we're about to do. Got it? One cartridge is 1.8 ml. Easy enough.
And here's our second magic number, which we can figure out pretty easily. A 2% lidocaine solution just means there are 20 milligrams of the drug for every 1 milliliter of liquid. So if our cartridge has 1.8 milliliters, we just multiply 20 by 1.8. And what do we get? 36. One standard 2% lidocaine cartridge has 36 milligrams of the active ingredient. That number, 36, is going to be your new best friend.
Now this formula, this is your key. This is how you figure out the dose in any situation. To find the total milligrams of a drug, you take the concentration as a percentage, multiply it by the volume in milliliters, and then multiply all that by 10. That times 10 is just a quick and easy way to convert the percentage to milligrams per milliliter. So for our 2% solution, that's 2 times 1.8 times 10, which gives us
36 milligrams. See? The math always works out.
So, how much is too much? Well, the maximum recommended dose, or MRD, is all about the patient's weight and whether or not you have a vasoconstrictor in the mix. For lidocaine, the limit is 4.5 milligrams for every kilogram of body weight. But if you add that epinephrine, the limit jumps up to 7.0 milligrams per kilogram. So why the increase? Well, remember that vasoconstrictor keeps the drug from flooding into the bloodstream, which gives the body way more time to process it safely. It's a bigger safety margin.
Theory is one thing, but the clinic is where it all matters. So let's put this into practice. We're going to walk through a real-world calculation for a pretty typical patient scenario, step by step.
Okay, here we go. Our patient is healthy and weighs 70 kilograms. We're using a 2% lidocaine solution without any epinephrine. Step 1. We have to figure out the patient's absolute maximum dose. So we take the MRD of 4.5 milligrams per kilogram and multiply it by their weight, 70 kilograms. That gives us 315 milligrams. That is our ceiling. We cannot go over that number. Step 2. We know our concentration is 2%, which is 20 milligrams per milliliter. Easy. Step 3. Now we just figure out the max volume we can give. We take our max dose, 315 milligrams, and we divide it by our concentration, 20 milligrams per milliliter. The answer is 15.75 milliliters. That is the maximum safe volume for this specific patient.
So, the math is done. You've figured out your maximum safe dose. But hold on. Before you even think about picking up that syringe, there is a final mental checklist you absolutely must run through. Think of this as your professional sign-off, making sure that all this great science translates into safe and effective patient care.
So here are the big takeaways, and these are completely non-negotiable. 1. Always, and I mean always, verify the patient's medical history and double-check for any allergies. 2. Just because you calculated a maximum dose doesn't mean you should use it. Your goal is to always use the lowest effective dose that gets the job done. That's how you minimize the risk of toxicity. And 3. Monitor your patient. Watch them. Talk to them during and after you give the injection. Your job isn't over just because you put the cap back on the needle.
From the tiny ingredients in the cartridge all the way to that critical final calculation, you now have the foundation. You have the knowledge. The only thing left is practice. So the real question is, now that we've broken it all down, are you ready to pick up that syringe and calculate with the confidence of a safe, competent clinician?